thank you for organizing this wonderful workshop. So I just want to apologize beforehand if you see any errors, because I'm really bad at typing now. So if there's any, but yeah. Oh. So who am I? I have a background in biomedical technology and physics, and I did am doing my PhD, depends on where you define the line, at the MS Center Amsterdam UMC of the Department of Radiology and Nuclear Medicine, and in the Structural Brain Imaging Group, which is led by Hugo Frenken. And my PhD was on aligning image analysis tools with clinical practice in multiple sclerosis. And now I also more or less started as a postdoc on the TACTIX project. And if you're tall, you're always in the back of the picture, but there you can find me.
We don't see young, there's only half young.
So this is the presentation overview for today. So why do we want to measure brain atrophy MS? Is it relevant? I think Menno already gave a bit of insight yesterday. So some of the things may be a bit of repetition, but that is never a bad thing, I think. Do we understand what happens when we talk about brain atrophy? Can we measure it actually in vivo? And can we use brain atrophy in the clinic finally? So, of course, you know, which Menno talked about it yesterday, that we can measure brain atrophy on MRI. For example, here's a scan of an MS patient over a couple of years. And you see that the brain parenchymal fraction decreases over the years, but it differs between the years also with what amount. But you see, for example, ventricular winding, and that the CSF becomes a bit, the gyri and the Silchi, they shrink. But something which is important to realize is that we quantify atrophy on MRI with brain volume loss, which is not actually atrophy, because atrophy needs to be pathologically proven and irreversible tissue loss, because your brain can shrink and increase in size as well. For example, due to coffee intake or more water intake, your brain increases or decreases in size. So that's something to realize. That's not actually, brain volume loss is not actually atrophy, but many studies have shown that it's really associated with atrophy and also levels of disability. And something, yes?
Maybe ask a question to me?
Yeah, for sure.
Maybe probably you will tell it, but is it the only marker then that you measure volume, or do you also include functional?
I will come back to that, but okay. the main presentation today is about volume indeed, but there's also other ways, for example, using diffusion to look at atrophy, for example. Yeah, but the main focus of today is volume, so anytime I'm talking about volume, it's more or less atrophy, brain volume loss, basically. So brain atrophy was thought to be a later process, but actually we know it occurs from the very early stages due to recent studies. It has a good prognostic value. It strongly correlates with long-term disability and cognitive decline, and it predicts clinical progression better than lesion measurements alone. And Menno already talked about this yesterday. You have different regions that are affected, such as the thalamus and the cortex, which predict progression. And this is a very nice study, I think, which was did by Armana Shaghi, where they studied 1,200 MS patients, and they had a nice follow-up with 7 European centers and a lot of scans. And you see in these graphs that a deep gray matter, so that's the gray plot there, is one of the most prominent regions that has brain atrophy loss. And this deep gray matter, but not baseline cortical volume, can predict future EDSS progression. What you see in these graphs here, if you want to read the studies, it's really nice, I would recommend that. But yeah, so we have different regions that are also affected. So it's not always one region, it's also deep gray matter, cortex, white matter, whole brain, almost everything is affected in MS. But some regions have better predictive value than others. And then another thing is that brain atrophy is very much linked to PIRA. So it's one of the, on the left, here they did an analysis between stable and people with experience in PIRA. Remember that it's progression independent of relapse activity. And you see that in patients with PIRA, they have increased brain volume loss in all these regions, which you see on this brain scan. And that's also the case if you look at radiological inflammation, so lesions in this case. Something which is striking, I think, from the left plot is that people have a very different trajectory. So every person has a strange trajectory, and I think we saw that in the slides of Menno yesterday as well. But it's important to realize that people who are worsening without relapsing have a steeper decline in their brain volume. For example, this purple, pink line has a steeper decline than people, for example, that are relapsing and non-worsening, or stable, non-relapsing, non-worsening. So brain atrophy seems to drive this progression very much. So I think also based on what we saw with Menno, that we conclude that brain atrophy is really relevant for MS. So do we understand what happens? The problem is that, for example, I think you all know what white matter and gray matter is, that we have many concurrent changes in MS. So we have lesions, we have atrophy of the ventricles, we have atrophy in the cortex. One is degenerative, one is inflammatory, but we also have, the arrow is a bit on the wrong, but we also have diffuse abnormality, so a lot of things is going on. And then it's also a story, what is the egg, what is the chicken, what is the egg, we don't really know. Yeah, and then also we need to actually know what are the reasons for this atrophy. So there's, several reasons, and I'm not a pathologist, but these are the things we normally think of. So there's diffuse neurodegeneration, which means loss of neurons and axons due to chronic injury. There's inflammation, that we have persistent microglia activation and oxidative stress. There's demyelination, of course, the pathological hallmark of MS. There's axonal transection, both in acute and chronic lesions, and the glial scarring, which impairs neuronal repair and plasticity. So there's a lot of stuff that can actually influence this brain atrophy. And then is actually what we're measuring actually happening? So is a volume loss really something that happens also on a pathological level? And this is a study done by Popescu, and there was a PhD student in our group, which is now already a professor, I think, in Belgium. So there they scanned in post-mortem study, so that's in situ scanning, meaning that you scan the brain as it is. And then they extracted these cortical volumes in those regions. And what they saw here is that in people that have increased or decreased gray matter volume, they saw less axonal density, they saw a smaller neuronal size, and also a smaller neuronal density. So that means that we actually, we're measuring something which is also has something, a pathological foundation. So that's, I think it's a good thing that we can measure actually something which also happens pathologically.
David?
Yes.
Do you remember how many people they included in this study?
It's not that many, I think like 16, 17, but for a post-mortem study it's quite a lot. Yeah. Yeah, not maybe it's somewhere between 10 and 20. I forgot the exact number. Yeah. But Menno, I think also told we do quite some post-mortem studies in Amsterdam, so I think there's now more available. The only problem is not many people working on it. So we're sitting on a gold mine of data, but we need more people to work on it. And then something else, like the chicken and the egg story. We don't know really what happens. I will show you also in the next few slides. But this is a nice study by Martijn Schoonwijk, where they looked at the relationship between atrophy and lesion load. And then you see that different gray matter structures, for example, the caudate nucleus or the putamen and the thalamus, they all have some sort of relationship with the T2 lesion load. And this is a bit different for the subtypes, but mainly if you have more lesions, you have more atrophy. That's basically what happens. And then Rosemarijn Mathiesing, who is now a postdoc in our group, she tried to unravel this. And they had a study with, I think, 500 people with MS. And they looked at what predicts what. So are lesions coming before atrophy, or is atrophy before lesions? And they had follow-up of 5 years, I believe, in total. And they showed actually that a higher lesion volume changes are linked to faster brain atrophy in treated MS patients, but also faster atrophy can predict increased lesion volume changes in the following year. So yeah, it's still a bit different. And they saw that in treated periods, this was a weaker relationships, except for central atrophy, which relates to higher lesion volume. So you see that year 2 lesion volume predicts year 3 atrophy, and these are all the significant voxels. And you see that in the 3rd year, the lesion volume predicts atrophy. Again, all the significant voxels. So it's still a bit difficult. What happens first? How can we measure it? What happens first? What comes next? And then this is also another study where we took a lot of scans. You don't need to know them all, but this comes back to your question, Klaus. That we can measure atrophy in a lot of different ways. So we can look at the neurodispersion index, or we can look at the factual anisotropy. These are all some sort of measures of atrophy, I would say. Of course, it's not perfect, but using this all together, we can get a complete picture, I think, at least with MRI. And in this study, this is early relation remitting, so they had to have a diagnosis of less than 5 years. So people are not really with a lot of treatment already. Some had, but could only be on first-line medication, a Dutch first-line medication in this case. And we see that lower baseline white matter integrity is linked to greater cortical atrophy in relapsing remitting patients with clinical progression over 1 year. We saw that baseline gray matter integrity does not affect white matter changes over time, but white matter damage appears to drive atrophy more than the reverse. Of course, now we think that actually white matter seems to drive gray matter atrophy. So if you have some sort of lesion in your white matter, you have cortical atrophy in the later stages. Maybe because there's some disconnection or something, we don't really know why. But this is at least in this study what we found. So do we understand what happens? No, not really, because we don't know if lesions come first or lesions come next. It's still a very difficult process, and of course the brain is super difficult. So there's a lot going on at the same time. That's what I think, just a lot of inflammation and neurodegeneration all at the same time. Then can brain atrophy be measured in MS in vivo? I think from the studies you can already consider. And then now let's consider that atrophy is more or less brain volume loss. From now on, I will consider that. And we can, of course, measure it with MRI. To measure local volume changes, we need anatomical detail, good contrast, brain versus non-brain, and good contrast between gray and white matter. And this is, of course, we can do this with a standard 3D T1 high-resolution scan. Well, I think some of the, how do you say, text doesn't come on. Anyway, the slides may be full. I want to do that in steps, but
okay. So
yeah.
There's
what we learned from Jan yesterday is that, the classical way of doing this is that you have a rater. To measure volume, you have a rater inpainting every region of the brain, what is what. And on this slide alone, you can already see that's a lot of work. And if you consider brain, you have a lot of voxels to classify, and this is way too much work. You can never do that, and I think a lesion takes already a few hours, and a lesion is a very small volume compared to the brain. So we can't use manual segmentation, but we need automatic tools. And there's a lot out there. This is a study we did where we looked at 6, but there's many more, and it's some sort of minefield, I think, always. I think it's always good to stick with what you know, at least, and to look at options that may be better. But some tools, they have been proven to be very much reliable and useful and have good prediction. Some things which I don't know for the tumor field, like for example, how you do that. But for MS, you need specific pre-processing steps. You need bias field correction. I think that goes for any sort of study. And what we then do is we do lesion segmentation and lesion filling. So what we're actually trying to fool the algorithms, because what you see is that in the places of the lesions, so for example where the errors are, you get this hypo-intense signal on the T1. And then the algorithm may think that this signal is actually gray matter or even CSF. Well, it's actually not gray matter CSF, it's a lesion tissue. So you get increased gray matter volumes in people with MS, which is strange, but it's actually lesion tissue. So what we do is we do something which is called lesion filling. I don't know if you're familiar with that. So what you do is you segment the lesion, normally on the flare or flare and T1, and then you say in that area I want the tissue intensity to be the same as the white matter, and then of course you already have the lesion volume as well, so you can correct for that. If you don't do that, what you get is that you will get erroneous segmentation around the lesion. So for example here, there's quite a large hypointense lesion on the T1. You see that, well, it can't classify it for this software. This software is really nice. It's very robust against anything. So this classifies it as we would do it. But yeah, depending on the software, there's some misclassification. So normally what you would do is lesion filling and MS. So if you work with volumes, that's the way to go. Or you take a software which is robust for that. And then again, there's many alternative methods for atrophy analysis. And then also, for example, in the spinal cord, we can look at atrophy. We can do brain partulation, cortical thickness. I think most of you know this, or otherwise I will come back to that later. Yeah, many different ways to look at atrophy. But for this talk, I will be mainly talking about brain volumes. So in that same study, they did a post-mortem validation of cortical atrophy measurements. And so here it says, 16 cases indeed. And they also looked again at the same MRI scan, and then they took the sections, and then with the camera they made a picture of that, and then they looked at what is actually the distance between this cortex and the white matter, and then relate this to one of these segmentation methods. And so what you see here is the Z-score of the histological cortical thickness, so that's based on the histology. And then here you see the Z-score of the MRI cortical volume in this case. And you see that after you sometimes you need to correct these softwares manually, unfortunately. I think nowadays they're getting better, so we don't have to do as many manual corrections anymore. But you see that after you do some manual correction, there's a good correlation between these regions. Of course, it depends on where you take your slice, for example. And the same goes for when you do a measure of cortical thickness measurement. I don't know if you're all familiar with it, but you can use, again, the same software to project these surfaces. Then you calculate the distance between these surfaces, and then you can get a thickness measurement. So, yeah. But the problem is, we have a standard 3D to 1, but there are many differences. You have different MR modalities, and especially in MS. You have different contrasts, and the same 3D T1, depending on your settings of your MRI machine, your gray-white matter may look different. You have different acquisition directions, slice spacing, if you do a 2D sequence, slice thickness, again. So there's many differences between hospitals, even within hospitals, even within the same scatter. That's pretty problematic. So how can we solve this? Well, there's a way to do this, is Bayesian segmentation, to look at both T1 and flare. So you have a generative model to predict your output, and then in inference you can put your input, and then you can actually use a T2. But again, this type of, sort of classical segmentation is quite influenced by, for example, slice thickness, etc. So, what would be the solution, and that's something they proposed at SynSec, for example, is to synthesize data and then train the CNN with synthetic data. So you very much corrupt the images, do a lot of stretching, translation, add noise, a lot of different image operations, and this will, and then you do the same to your output, exactly the same, and this will hopefully in the end learn your algorithm to deal with these kind of things. And I will just show you some examples. So this is all the type of operations that you could do. And then you can overlay your segmentation on that. And then hopefully the model, in this case the deep learning model, will have learned how to deal in the future with clinical scans where you have the same problems actually. And these are just some examples of all these generated scans. You see that they're really not realistic for a clinical scan. But using this, you can actually train a model. So they did 1,000, or I think it's millions and millions of these type of synthetic scans. And using that, you can train the model. And of course, you need your label map to do the same. And this is the SynSec algorithm, which I think it works really well. And actually, something we have also a group that looks at white matter leukodystrophies, and that's where people really have strange brains because white matter is almost water-like, so they only have a cortex left. And even on that, this algorithm works quite well. So we're really, yes. No, I'm quite impressed with what the results they get, yeah.
The synthetic segmentation, I think it's an in-house software. Is that correct? Written by or?
It's by Benjamin Billett, which I think is UCL.
Okay.
Yeah, you can just download it, use it. If you have free server, it's in there. So.
Some of these images don't look like brain.
Yes.
They are not correct. You can't tell. So, is there a way to maybe like take some of these and now say don't use these as the training data, or?
No, but that's why they use it, especially to make it as robust as possible to any kind of input you have. Mm-hmm. And that actually worked. If you now have a brain which looks a bit of strange, it probably has seen it before in the training because they did a lot of stretching, etc. And I think that's the strength of the algorithm, rather than a weakness. Yeah. And then, of course, you can do different versions of these training maps. Of course, it only does what you tell it to do. So if you don't say there could be, for example, a skull around the brain, or we have some CSF in there, or, for example, we have lesions in there, it doesn't classify it. So that's something you as a user should do. And then, of course, in MEST, it would be nice to have these lesions segmented as well. And then just a bit of a training overview. I think this is not really relevant for this talk. And you can do the same by synthetically. Sometimes what people also do is they have, for example, T2 scan, and then they first make a T1 out of a T2, and then you can use that T1 to segment the image. But you can also use the one-go step, which is SynSec. Then something which is a main focus of my PhD as well is that we look at reliability, because you want, if you have a patient, and I saw in this hospital as well, they have a Prisma scanner, 1.5 Tesla, they have a Vida scanner, so lots of different scanners, and I think in any clinical hospital they have a lot of different scanners, they get upgrades, they get software upgrades, hardware upgrades, people switch between hospitals, so these different types of settings of your scan sequence parameters, they change over time. So we want the thing we want to measure should actually be a pathological measurement rather than a technical problem. And in this study, it's a bit of a big scheme, but 21 people with MS, they were scanned repeatedly on 3 different MRI scanners, a GE, a Toshiba, and in this case a Philips as well. And then what we also did, we scanned them, took them off the scanner bed, they walked around for a bit, and they repositioned and did the same scan again. So scan and rescan, and then repeated on 3 different scanners. We did lesion filling and non-filling. I will not talk about that today, but we used these softwares in this case, and then did some analysis. I think the screen is it's not good to see, but we looked at how reliably can you measure if you want to measure the same person in the same machine. So that's the maximum accuracy or maximum reliability we can get, and how reliably can we measure it if we transfer people to the machine, more or less mimicking the clinical situation which we end up in. So again, these softwares which I showed you, and this is something I wouldn't look at the numbers, but this is basically if we look at the same scanner and an interclass correlation coefficient. Who is not familiar with that output? I mean, anything above 0.9 means excellent reliability. And you see that within scanners, that for most of the software, depending on the region of interest, we see that we have excellent reliability. So you can actually reliably repeat the same scan. But if we look between scanners, we see that this situation is a bit worse, depending again on the software and structure of interest. But unfortunately, we always see systematic differences between scanners, irrespective of the software, if you move to different scanners. So these are the different scanners, again, in the box plots. And we see that, I mean, depending on the gray matter or white matter, and also depending on the software, but there's always systematic differences. And something which is important to ask yourself is, yeah, sorry for the text always on the same slide, but is this systematic difference as large as the thing we want to measure? People with MS, they have a atrophy of about 0.5 to 1.5% per year. And we can look at the standard error of measurement and the smallest detectable change. The smallest detectable change is a measure that says I can reliably measure this volume change if I are within scanners or between scanner situation. So you want this measurement to be between 0.5 and 1.5% per year, more or less. I mean, something between 0 and 3 I would consider good, something higher than 3 I would consider bad. And we see that for the within scanner situation, we are more or less in the range we want to be, but we see that for a between scanner situation, we are not there yet. Yes?
Yeah, I have a question.
Eh?
Yeah, well, between scanner doesn't mean the systems, so you mentioned various systems. Is it, for example, larger if you have various different field strengths? Is it larger? So have you identified the main sources of difference?
Yes and no, depends a bit. But interestingly, we did another study as well with more or less a similar setup, and we saw that we had 2 Siemens scanners in 1.5 and 3 Tesla and a GE scanner in there, also with repeated scans. And we saw that the Siemens were very much similar, and I would have expected that the field strength would have mattered more, because you have noise, of course, in there, more noise, the lower field strength. But actually, having the same vendor actually is more reliable than having different vendors.
Yeah,
and in this case, there were all 3 Teslas, so this is all the same field strength. Yeah.
Because so maybe that's like ages ago. There are large cohort studies, and I just know from Germany because maybe it's processing all the MR data. So there's a national cohort study with 30,000 full body scans, and when they decided to set up this study, they of course had to ask for offers from all major vendors, but it was clear that in the end, surprisingly, they chose Siemens in Germany, but they all picked the same scanners and still had even though they had identical protocols and identical software, so basically everything identical, they still could see differences in certain metrics.
Mm-hmm.
So you would then say it's maybe purely on the operator, maybe purely on some environment which is not so constant.
Yeah.
Maybe it's something stupid like air pressure or temperature.
Yeah.
But I think the question is, so, and that is probably in line what you confirm. If you run a flare or like the T1, IDT1 weighted sequence that GE offers versus one that Siemens offers, you would expect similar things because you have the same PR, but it already of course starts because the protocol parameters not necessarily, even though they have the same name, they are not necessarily, if you look into the sequence, exactly the same, and that is something what Gamma Star, for example, will tackle.
Yeah.
Or it is really for this multi-center comparability because you want to bring same physics to the basically to the event blocks. But
Yeah.
then of course how the hardware realizes this block, that's then something you cannot influence by software.
No.
Then the variance between the hardware, but I think that would be really something we are in the project, so we could also, if we have, I don't know how far we are, if we have another driver for either Philips or GE, we could try to have like a small sub-study of what you did and compare that to see whether it gets better or not. That would be interesting.
Yeah, I mean, it would even be interesting because the Siemens here is a Prisma, right? Which we
have a Prisma.
But the protocol you're doing is Prisma, and we have a Vida. So
But there's
that
a
would.
Vida there too, actually. I don't know if
Sorry?
there's a Vida there too. It's just possible.
Yeah.
I think Prisma is more stable.
Yeah, but I mean, we could already look at those differences. Yeah, I think there. To be honest, I think there are differences there already between the Prisma and the Vida. Yeah.
Yeah, of course.
Even though you implemented exactly the same TR, TE, etc., I think the gradients are slightly different, probably between the scanners. That will give you a slightly different result.
Yeah, but that's then the question how you realize it, because, for example, you could, of course, you can, of course, implement a sequence that you say, go, for example, maximum gradient stop, depending on the hardware. Or you can say, that's what I mean, same physics, I implement the sequence, checks the profile of the scanner and says, okay, I want to compare two different systems, and I know that the weaker system has the max slope of these. So I also force the more powerful system to like downgrade the gradient performance just to increase comparability.
Yeah.
That's what I mean.
No, that's a very good idea. Indeed. Something also I discuss in my thesis discussion. That we should implement those kind of proposals as well. Yeah. Did you have a question?
Actually, I wonder about, like, you showed difference between the scanner and between the scanner, and how many data that you have that for same patient having different scans from different machines?
This is 21 patients in this case, and that is for a reliability study such as this is quite a big amount because people in the end, and I have actually this study, they were scanned I think within a week. And then I actually also executed the study myself where I scanned them within 4 hours. So then you also don't have time missed day effects or coffee intake, or we controlled it really. So it's only about the scanner actually. And then we also see the same thing. But for reliability studies, people have to, I mean, we're scanning, in the end there was 512 scans because you have so many repeated scans. So that's more or less for a reliability study, the maximum amount, which I've seen. I think we're one of the largest study doing this.
I wonder about, like, if there is a deep learning model or something to somehow, let's say, get into the data from GE to Siemens, like converting like generative model. You show like getting them from that intensities to the Philips intensities or Siemens. Good remark. I will come to that in a bit later of the presentation. And then something else which I think is striking. So here we looked at the amount of participants you need. So it's a power analysis for a within scanner situation or between scanner situation, and then divided those. And you see sometimes you need a twofold amount of participants to detect 1% volume difference. And that's already quite large for MS, 1%. So that would mean you need to scan additional 1,500 patients, and that would mean, of course, a lot of extra money. So you would want to go to the within scanner situation.
What are the parentheses, David?
That's the amount of participant needed for a within scanner situation. Yeah.
How
So
do you estimate that? Like,
it's so you can
16,000 is there, so
yeah, it's a power analysis, so you can actually yeah. So with a variance component analysis, you can estimate the variance, and then you can do the power analysis after that. And then we also looked at where these differences are actually located. So if you, for example, in this case, we show that, for example, in the top row, we see that GE is very often larger than Philips. And for example, in this case, it's already a bit more variant. But if you compare Philips to Toshiba, and if you look at this figure here, you don't really see a large difference between the two. But if you then look locally, you see that it very much differs between regions, so they cancel each other out. So depending on the region of interest you're interested in, you need to take care also again in this type of information. So is there no solution? So this is again more or less the same study where we scanned 30 people with MS and 10 health controls. Also we did a 1.5 year later follow-up. We scanned the same sequences, T1 and FLAIR, and then in this case, we did a 3T Tesla Siemens and a 1.5 Tesla Siemens and a 3T GE, if you're interested in the protocol. So I really liked this approach, which comes back to your question. This is called HACA3. And what it basically does, it learns all the different things we can see in the MR image, example anatomy, contrast, and also artifacts. It can handle missing contrasts. And then it will translate the contrast of one MR machine to another. The nice thing of this is that normally we would need a paired data, so a scan and rescan. And then of course we did this in these studies, but if you have a software upgrade, which happens every, 2 to 3 years I think, if you have a new scanner, you would need to do that again. And then you would need to scan a lot of people all the time to be able to update your system. And this approach, tries to tackle that. So you don't need paired data, but what they do is they intra-learn the contrast between the different, within a participant. And then something which is important, a lot of these deep learning models, they have this, they have this, they say to the model that the anatomy between the different contrasts should be similar. Well, actually, this is not the case. For example, if you look at this T1 and FLAIR in that region, you see that the anatomy is quite different. But it's the same participant, same scan, they didn't move their head. So this is something which is not always true. It depends on your type of sequence, how the anatomy looks like. And of course, you can also imagine that in the cases where there are lesions, for example, the anatomy is quite different. So they actually said you don't need to be that similar.
Sorry?
Yes.
So your algorithm, so is it your algorithm?
No.
The algorithm maps similar contrast to each other. So you have intra-contrast mapping,
Yeah.
and not inter-contrast, so not T1 to T2 also, that's often also done. And it is, so let's say you map a Philips to a Siemens T1, or you map a Philips FLAIR to a Siemens FLAIR.
Yeah, no, it doesn't really do that part. It does really within, and then it has a anatomy encoder. It has a contrast and artifact encoder, and it actually takes the contrast, which is generally the most important part, and then encodes that contrast of your target image. So you need to take your contrast from your input, that contrast from your output, and then it synthesizes eventually the target contrast which you want.
So, yeah, so basically you set up an architecture which has some handcrafted features because of the architecture, so anatomy, contrast, and anatomy and contrast, let's say in these.
Yeah.
Then you get a representation how you map one contrast to the other contrast, like a blender.
Yeah.
And then you take that map, but keep the anatomy.
For example, indeed.
Okay. And is this trained for a system specifically, or does it not need to be trained? Is it?
Yeah. In the end, you need to it doesn't need to be trained indeed. So you can have any target image which you want, and you can have any input image. So it's not a system specific.
It's a single stage training basically. So you have a base trained model, but then if you have a, let's say completely, so if I have a new scanner,
Yeah.
I could use this pre-implemented network,
Yeah.
and just it learns directly from that one single
Yeah.
sample the mapping contrast to contrast, and then can synthesize the newly generated image.
Indeed, in principle, it could do that, and we actually see that it. And I will show you some results in the later few slides, and we actually see that it actually does this quite well, but it's not perfect. So we're also in collaboration with the developers of this algorithm, and we want to see if we can add a few more scans where it actually improves the training. Of course, that always happens, but the nice thing is that you don't need paired data. And I mean, if you turn on an MR machine for one day, they only train with 10 people per site, so it's really not too much scans. And I mean, seeing as the scans run here 24/7, you can actually take a few scans and then retrain the algorithm. And the training is a day or something. So it really, if you have a new software upgrade, you just scan 10 patients, get that data, retrain the network. At least that's my philosophy. And also we need to see whether that works, because we're looking at that right now. But already the basic model is already quite promising. So what they show actually, for example, and this is something which you can of course imagine, that you have different visits, and then suddenly at visit 2 it was scanned on a GE instead of a Siemens, and you see that the cortical gray matter volume jumped up, and then if they harmonize that image to your target, in this case probably then the Siemens, you see that it nicely follows a trajectory which you would expect. Yeah?
That's interesting. So, but the visit 2 there, which is then the harmonized one, so less, like, this is on the line again.
Yeah.
Where did the anatomy then comes from? If
So,
you, like,
the major thing here is the contrast difference.
major thing is the contrast. So you keep the anatomy nonetheless. So you take technically the harmonized visit 2 is, like, roughly speaking, so you only have 4 scans.
Yeah.
So basically the visit 2 harmonized one is a synthetic image out of anatomy, roughly, out of anatomy of visit 1, because you don't have visit 2 at that point, visit 3 at that point, and the contrast of visit 2. The harmonized contrast of visit 2.
Yes, but of course you have trained that algorithm also before, and this is, so you had several subjects again before.
Where does the anatomy come from? So if visit 2 would have different anatomy for pathological regions,
Yeah.
reasons,
Yeah.
that would not be really reflected, would it?
The anatomy would be reflected, but the contrast wouldn't be reflected.
David, I wonder about a brain tumor as an example. If that
Yeah.
is a brain tumor, I think this would be risky, I feel like. Have they tried it?
They did it with MS subjects, and there we actually saw good results. Of course, in MS you have lesions, and they change quite frequently,
Right.
as we know. And there we saw actually that it worked. On my data, I saw that in some cases it sometimes either slightly decreases or increases. So you should be wary indeed of those cases.
Right.
And I think it would need a bit more refining example for tumor models as well. And that's also something which we discussed with Jan yesterday, is that it's not going to be perfect as a algorithm, just you can take it off the shelf and use it. I think you should always try to tweak it a little bit. We expect a lot of these deep learning algorithms to do everything we want, but I don't think that's the reality. We need to tweak it, but I mean, their off-the-shelf method is already quite promising, so I'm quite happy about it. Yeah.
The architecture of the algorithm, can you go on to it? So is it something like
the architecture is, it's a variational autoencoder, but I think if you want the architecture, it's quite elaborate, so you can take a look at the paper. That's better. I don't have it in the slides, sorry.
Okay,
Yeah.
just to make it exact, so it's a variational autoencoder?
Yeah, more or less. There's some differences, but yeah, they explain it a bit better there indeed than I can do it now. How we are for okay. And then just to show you some examples, I don't know I think it's a bit bad, but you see that there's a bit less noise if you simulate a SOLA, which is 1.5 Tesla to the 3 Tesla. And also what I think is you get a slightly better definition, but that's again a bit problematic here. The cortex here is not really well defined, but here it's a bit better, but that's if you have a proper viewing station. Something which is nice, I think, is that here this person had a bit of motion artifacts. I don't know if that's possible to see from there actually. Not really, but it actually removed that quite nicely. So the artifact encoder also works well. Can you see it? Well, there's a slide of ghosting motion artifact that is removed in the other image as well. So that's actually, which I thought was also promising, which improves the quality of your images in the end.
David, there's also another note. I feel like, the algorithm does denoising on top of just harmonizing, so that might also be risky for subtle lesions. Some of the images that Vera showed had like really subtle MS lesions. So I would wonder about, how it would affect especially those subtle ones.
Yeah, indeed, and that I think comes back to the question that you would need to look at those things as well. But yeah, what I've seen is that it actually made the lesion a bit crisper, so nicer edges rather than these vague edges which you sometimes have. Of course, you need to be very wary of this effect, and you need to look at the images originally and see whether it translates it well. Yeah. So that's what I'm saying. It's not the perfect solution, indeed.
It's smooth.
It's smooth, and there's a bit of loss of effective spatial resolution, in my opinion, as well. I mean, yeah, it's always a bit of a trade-off, I think.
How about loss of personal, like marker of like fingerprint of the person, of individual subjects?
Well, it doesn't generalize to all the specific subjects, and that's something I want to show in this slide as well. So this is the situation where the volumes are unharmonized, and you see that, and this is the same subject, so a line corresponds to the same subject. And this is, of course, this is the variance within the subjects, and these are the different scanners. And what you can see is that there's quite different mean absolute differences between them, and they're larger than the range we want to measure. But remember, because we want to measure something like 0.5 to 1.5%. And if we then harmonize them, I mean, these tests are really sensitive. So if you have 0.01%, 0.01% difference, 0.0001, indeed, you actually already test the difference. So don't look at that, but the measures I'm a bit more interested in, and it's really the region we want to be in. And you see that you don't really lose much of the variance between the subjects. So that's also good. And then we also checked whether these are more or less the same subject, and that's also true. So you keep the same biological diversity in your sample. Something, yeah.
You showed another slide, like you were showing the differences between the vendors. Like one of them have the plus parts, positive parts, and the negative parts, and they are cancelling them.
Yeah, yeah.
So the figure now you are showing, is it like not this one?
Yeah.
Is it like the case in here also? Like
we haven't been able to look at that. So we're planning on that eventually as well, but we haven't been able to. I don't know. This is the honest answer. And the nice thing is that if you look within the same scanner, so that's the maximum accuracy situation, we see that the effect sizes remain similar and also the same direction, of course. And that's something we want. So you see that for most of the structures, MS have smaller brain volumes than health controls. Of course, this is reversely true for the lateral ventricles, which increase in people with MS. So can atrophy be measured in vivo? Yes, but we need reliable measurement for implementation. Plus, there's an interaction of the technique and pathology. So this is really a shame. Sorry for this large slides. So can we actually implement this into clinic? And for this, the Quantitative Neuroradiology initiative has been set up, which has sort of 6 steps of translational pathway. So to bring something to the clinic, you need to establish a clinical need, develop a method for automated analysis. We're there communicating biomarker results. We're also there validation. I think there's many papers validating all these algorithms. But then we need workflow integration and in-use validation, and especially those last two steps are quite difficult. And there's actually three types of testing. So you need technical validation of tool performance, for example, compared to a manual segmentation or other segmentation techniques. You need clinical validation by clinicians or by interpretation of the results alongside clinician-related variables. And in-use evaluation such as health economic assessment. Is it really beneficial actually to use this tool in the clinical care? And this is a nice study by Zoe Mendelson, where they took FDA and CE labeled software. So actually they all were approved. And they looked at the literature of how much validation there was. And we see that generally a lot of them have technical validation, at least these are the amount of papers. So it's not a lot, I think. Some of them have clinical validation, but only one of them had workflow or in-use evaluation. So this is really something, that's also I think why the adoption is very low. You see that a lot of companies are now out there, but not many have been implemented into the clinic. So that's also something we want to work on, and we have been working on. Yeah. Something else we need to consider, what is relevant atrophy? And that's, no, it's a shame, but imagine you didn't know this. So there was a subject who had a brain volume loss of 12 millimeters. Is this relevant atrophy? Who could tell me? I think nobody could. So you need some sort of baseline, right? So if we now know that the baseline volume was 1200 milliliters, do you know if this is relevant atrophy?
Little.
Yeah, maybe. It's like 1%. But also people, remember that people with healthy controls, they also have atrophy. So you need some sort of distinction. And this is a nice study by De Stefano, where they looked at what point should you cut off and what would you consider pathological. And they looked at this study and they said, well, more or less 0.4% is a good cutoff for MS to differentiate between health controls and MS. And then so this is more or less the cutoff which we use now. So more than 0.4% annually is really pathological brain volume loss. But then you will need multiple scans. And if you want to make a prognosis, for example, for a patient, and it has his first scan, how could we do that? For that, I think we need a reference curve. I think most of people know what this actually is. So you have a normal population, and then you have a brain parenchymal fraction, and you plot them against these reference curves. Same as when you were growing up and you had this height, and your parents could say, you're on that, you're on the right trajectory of growing or not. And we can do the same for MS. Problematic is that a lot of these reference curves are actually based on health controls. And people with MS, remember, have atrophy from the get-go. So most of them are in this region. So it doesn't give you a lot of information because you want to know how well your patient is doing compared to other patients. So in this study, we took roughly 1,000 participants. 3/4 were MS. You don't need to look at that at this table, but it's basically 1,000 participants, and we tried to develop one of these reference curves. And interestingly, if you plot them against age, you get a slightly different picture than if you plot them against disease duration. But this is just to confirm that indeed health controls, they are a bit higher, they have a bit of a higher brain volume compared to people with MS, and also the slope is slightly different depending on the disease type. To explain the next results, I just want to come back to this. Same for EDSS. If you have a longer disease duration, you might have a worse EDSS. But if you have a high EDSS and a very short disease duration, you're doing quite bad. So what they did in the study, they looked at, okay, if we have a reference population, can we more or less say whether the EDSS is bad given the disease duration? That is called the Multiple Sclerosis Severity Score. So if you have an EDSS of 9.5, which means almost death of MS, at the year 0 you have a very high MSSS. And if you have MS for 30 years and you still have an EDSS of 0, you're doing really well compared to the population. So just keep that in mind for the next few slides. So this is an example of one of these reference curves we've made. And then this meaning the lower quartile. In this case, we divided them as quartiles, not in percentiles. And then this green dot represents a person who's 54 years old, has a disease duration of 10 years, and has an MSSS score of 1.7, meaning that she's doing quite well. But the person here is more or less the same, also a female, also more or less 10 years of disease duration, also more or less 53 years old, but she has an MSSS of 7.18. So these allow you to differentiate two patients which have very much similar age, disease duration, and sex, etc., but they have a different type of disease. And in this study, we actually, I will maybe because of time, we actually showed that if you use these MS reference curves, or we compare them to the health control-based curves, sorry. So you have a health control-based curve and a MS-based curve. And we saw that if you do actually apply a MS-based curve, you can better discriminate people rather than the health control curves. And this is for the MSSS, but also we saw that for cognitive measures and hand function. And I think what is really interesting is that using these MS curves, so I think we should always use MS curves rather than health control curves, you see that you're better to discriminate who will be cognitive declining in 5 years. Because people in that lower group, so you, for example, as a neurologist, you have your patient, you have the scan, and then he says, how will I be doing? Well, because you're in the lower range of the brain volume curves, you probably will decline more rather than the people who are in the higher range of the brain volume curves. And these should be specific for MS because everybody already has a low brain volume when they start the disease. Something which we should be aware of in all these type of curves is that, and this is a really nice study, the Framingham Heart study, where they looked at the brain or intracranial volume of people in decades. So, and interestingly, they found that the brain actually, your brain is actually dependent on how big it is, depending on which decade you're born in. So, as humanity, our brains are getting bigger over the years. So this is something we should be aware of when we also make these reference curves, is that a brain volume is different if you're born in the 1980 compared to 1940, for example, on average, yes.
But David, I mean, these 1930s people, their brains were measured recently, right?
No.
Aging, when was it measured? Like, was it in their 20s?
Yeah, so this is also corrected for age. I need to check exactly how it is, but it is not that all the brains at the same time. So they're all measured when they're 30, for example. I forgot exactly how they did it in this study.
I mean, we didn't have MR technology at that time.
No.
Like how it works. So.
No. But they corrected that for the decade you were born in, indeed. Yeah.
And even then, our brains are getting bigger.
Yeah. So that's a good thing, I think. Thinking about what is slightly different is that the cortical thickness decreases, but yeah, I don't know how that plays out. But this is what we call brain reserve, and it also seems to have some sort of protective effect against cognitive decline, etc. So it's the younger you are, the better it is. The later you were born, I think. Unfortunately, we cannot change that.
Good news, but
yeah, it's good news. And then something else we should be wary of. This is a study where they looked at the same study which I showed before from our group, where they looked at 5 years, and they looked at treated versus untreated group. And the treated group is this blue color, and the untreated group is this pinkish color. And you actually see that people who are treated, they have a lower lesion volume. That's a good news, I would say. But something else is what you observe is in this first year again, you see that actually those people, they have a larger loss of their brain volume. So that's, I would say, bad news, but who knows what might be going on here. No? So this is what we call pseudoatrophy. So when you give somebody treatment, you have resolvement of edema, for example, and this will shrink your brain more or less. So that's what I'm saying. Brain volume is not always atrophy, and we should be wary of effects. So if you switch a treatment, we should always do a re-baseline after several months, just to make sure that we don't see a treatment effect. And then again, in the late years after that, we see a switch again. So we see that people that are on an early treatment, they have a lesser loss of their brain volume. So that's actually good news. But always we should be aware of these effects. So treatment also has an impact on brain volume. Unfortunately, we don't, in the Netherlands at least, we don't, I don't know how it's here. Do you scan a 3D T1 in the clinic for MS patients? No. And I think also Eva and Vera said that we don't scan a 3D T1. So that's unfortunate. It's also a bit of a...
Do we have it in the Acıbadem protocol?
Yes, it is in there, yeah. For research we do it, but in the clinical care we don't have the time, we don't have the money, and we really tried it, but we can't get it in through the insurance. So we should look at other ways. And this is a study I did together with Samantha Notenboom, and there we looked if actually we can utilize the FLAIR, because remember those sequence adaptive models. We can utilize the FLAIR for the same volume metrics. And then actually we saw that volume ICCs were really good, so they're all above 0.94, I think, a bit depending. And something else is that we can also discriminate. So this was our, let's say, bronze standard, free surfer on a 3.1. Everybody uses that more or less. And we actually see that we can more or less have the same effect sizes as we would have with a 3D T1. So that's actually good news. And something else is that we have the same regression coefficients on motor and cognition output. So this means that actually we can utilize the 3D FLAIR for these volume measurements as well. And then lastly, I want to talk about this study. This is a questionnaire we did through Europe, through the MAGNIMS Network, where we consulted 78 expert neurologists and radiologists about what do you actually want as a clinician. We tried Turkey as well, we didn't get any response. But I didn't know you that back then, so... but of course, a lot of these companies, they start and think, oh yeah, we have a really good software, we're going to implement it, but they don't consult the clinician first with what do you actually need as a clinician and what can you actually use. So we tried to do that in this study. So we use a Delphi panel method where we send a questionnaire, get the results, updated the questionnaire, get the results again. And then I'm just going to summarize this because I think the tables are going to be a bit boring, but if you want, it's hopefully coming out soon because we had minor revision, which is nice, in European Radiology. And there it lists all the important features which you actually need to include according to these clinicians. So why Q reports matter, Q reports, and in this case atrophy, that's their term, so quantitative reports actually. They enhance the diagnostic accuracy and improve monitoring and prognosis in MS. They provide comprehensive data on inflammatory and neurodegenerative processes, which you normally don't use that much, and should always be an aid for the radiologist and neurologist. There's increasing MRI utilization, and automated tools are underused, as we also showed that almost only 30% used one of these tools and even less in clinical care. And this has a significant barrier preventing wise adaptation in clinical practice. I think one of the most important things that people had affordability and their integration. So they didn't know how to use it. They thought it was all difficult. And of course, in the clinic, you don't have a lot of time, so you don't want to spend a lot of time finding out on how to use that. So they should be easily integratable into PACS and electronic health record systems. They should develop real-time automated pipelines, so you don't want to wait 3 or 4 days for the results. You want it tomorrow at the latest. They're quite costly right now, and we don't have a lot of money. I mean, all the money is going to the MR scans here in Turkey, and all the money is going to the treatment in the Netherlands. So, and we should demonstrate actually that this saves time also for the radiologists, such as, I was quite astonished that here the radiologists work so much time, and hopefully these reports could help him or her with their assessment as well in the clinical care. And we need to educate clinicians on how to use these reports. So what we should do is foster collaboration between software developers, clinicians, and healthcare institutions, and these papers hopefully could serve as a guideline for that. We should advocate for funding and policy changes to support these Q reports, align efforts globally to ensure accessibility and equity in MS care, and hopefully these Q reports can transform MS management through precision diagnosis, personalized care, and improved outcomes. So, can we use brain atrophy in the clinic? Yeah, if recommendations are adopted and software is highly validated. Something which we still need to answer is when to switch treatment based on atrophy, because we don't have trials yet. So we should set up clinical trials and to see, yeah, what should I do as a neurologist if a person has this much atrophy? We don't know. So that's something we should do in trials. With that, I would like to thank you for your attention, and if you have any questions, please let me know.